Ready? Great. Looks like we're recording. Thank you, Bammy. Right, so welcome everyone to this Expert Voices seminar. My name is Claire Ely, and I'm the head of Innovative Practice at the Centre for Justice Innovation. I'll start by saying a little bit about the centre itself. So we are a not-for-profit organisation that seeks to build a justice system which every citizen believes is fair and effective. We believe the justice system should be focused on solving the issues that drive crime and social harm, and it should be fair in how it treats people. We deliver a range of work to deliver that vision, such as we provide hands-on support with practitioners, so we work with police and youth justice services and probation, and we also conduct research into how things work right now and how they could do works better in the future. And we also promote evidence-based innovative justice policy reform, so like the one today. And just to say, we do work across the criminal justice and family justice agencies. So this Expert Voices seminar series is at the heart of the approach that the Centre has, and this seminar is the second in our series. The first was on neurodivergence in the criminal justice system, which you can access on our YouTube, and we'll put a link in the chat as well if anyone's interested in watching that one. So the Expert Voices event series seeks to discuss key issues affecting the justice system, and it's free and open to everyone, aiming to be accessible for people from a range of backgrounds and prior understanding. It's part of a much wider programme of work that we do at the Centre to promote the voices of both practitioners and academics who are leading on crucial issues that cut across the justice system. It is also linked to a range of blogs entitled Expert Voices and to our map of innovation. Both you can find on our website. And our map charts innovative projects happening across the UK systems. And we'll pop a link, excuse me, we'll pop a link into the chat for both the map and the blog in case you're interested in having a look. And if you want to be on our map or would like a blog written about you, let us know. We're always looking for new ones. So for today's seminar, which is about police moving away from police responding to mental health crises, we are very privileged to have an excellent speaker who will speak to you sort of roughly 15, 20, 25 minutes possibly, and leaving plenty of time for a Q&A event. Now, unfortunately, we were supposed to have another speaker, Ebony Morgan, from the Mobile Crisis Intervention based in Los Angeles, but unfortunately she's got COVID, so has been unable to join us. So hopefully we'll be able to share with you some of the information that she was going to do at a later date. So huge apologies, but it does mean that we have much more time with our other speaker. So I'm just going to introduce her. So I'd like to introduce you all to Chief Superintendent Tracy Bradley from Humberside Police. Tracy is the lead of the Right Care, Right Person, a model that started in Humberside and is due to be rolled out nationally across England and Wales. This is an operational model that changes the way emergency services respond to calls involving concerns about mental health, aiming to ensure that vulnerable people get the right support from the right emergency services. Tracy will share her insights from leading on the implementation of Right Care, Right Person, as well as touching on why we need to move away from an over-reliance on police responding to mental health calls. So we've got a great presentation sort of lined up, which I hope you'll enjoy. And then after that, we'll have ample time for a Q&A. So type your questions in the chat box throughout, including your name and where you're from, and we'll make sure we get to as many as we can. So thank you. I'll hand you over to Tracy.
Thank you very much for such a warm welcome, and it's great to see so many people here today. My name is Tracy Bradley. I'm a Chief Superintendent in Humberside Police, and I've been leading the Right Care, Right Person programme for the last 4 years. So what I'm going to do today is just give you a little bit of an overview in terms of the background to Right Care, Right Person. I'm going to touch on some of the principles we use for the programme, the different phases of work it involved, and then finally the results of the evaluation. And I'll try and leave plenty of time for questions and answers. So just in terms of the background then, so our journey started probably about 4 years ago now, in 2019. So at that point in time, I was the superintendent in our force control room. So I could see on a day-to-day basis just how challenging it was for my staff here due to the sheer volume of demand coming through the door. So I did start to have a look at this initially from a demand perspective, but I'll come on to it later. Although there was significant savings in terms of officer hours, our guiding principles is really around what is the right resource with the right skills and ability to be able to deal with whether it's health or social care. But in essence, when I started to have a look at this, Humberside's probably a medium-sized force, and I started to have a look at concern for welfare initially. So we're talking 25,000 calls per annum. It accounted for 11% of our overall demand. It was our second top incident category in terms of volume, and it was rising exponentially. So year-on-year increases. There'd been a 25% increase over a 2-year period. And then on the other hand, we had mental health. So again, big numbers, 14,000 calls per annum. It accounted for 6% of our overall demand, and we'd seen a 35% rise over a 2-year period. And we looked into the detail in this. So we did a little bit of analysis, and in policing, we have what are called kind of top locations, top callers. And what we found was, and that figure's wrong there, it should say 30%. So 30% of concern for welfare calls came from our partner agencies. And in terms of the top locations of repeat callers, 8 of those top 11 locations were NHS or care settings. So significant demand around concern for welfare for mental health, and that started the journey really to have a look at what exactly is going on here and what can we do differently about it. So we started the Right Care, Right Person programme, and we have a number of principles that we operate to in Humberside, but our primary principle, our overarching principle, is that members of the public have the right to receive the right care from the right agency. And as I said, I'll come on to the results later, but I just want to make the point that even though there's been significant savings in officer hours and definitely an efficiency element to it, this has always been, and we've been really, really clear about providing the best service to the public. And when we talk about health issues, whether that's physical or mental health or social care issues, often the right agency isn't the police. Our colleagues in ambulance services, acute hospitals, mental health crisis suites, and social services are often better placed to respond. They've got the appropriate skills, training, and in many incidents they've got that ongoing relationship with the caller, so they're better able to meet the individual care needs of that individual. So I know there's definitely been kind of some concern maybe in the media around police are walking away from mental health, etc. Actually, we're not. So where we have a cause to use our police powers, where somebody is in crisis, if somebody is, on the top of a multi-storey building, if somebody is weaving in and out of traffic, if somebody's hanging on the side of a bridge, absolutely, that is the place where the police should be, because no other agency is going to do that. So where we're talking about immediate risk to life in a public place, that's us, and we do go to that. But often, when we're talking about mental health and all of the research that's done by national charities, etc., when people are suffering from their mental health, the last people that they want to help them is the police, because it makes people feel criminalised, stigmatised, and the mental health deteriorates further, and they carry that additional stress with them into the future. So for us, this is about making sure that as a system, and yes, Humberside Police have been a key part of that, but this is a partnership endeavour. So as a system, how do we provide the best possible care to people who are suffering from mental ill health. And as I say, often that's not the police. So the next principle is that the police should concentrate on their core policing duties. And I think by osmosis, really, we've accepted responsibility for mental health and social care issues, even to the point where we've developed plans, we've invested in training to be able to manage that additional demand. And, you know, we really haven't stopped to think, you know, what are we here for? What's our raison d'etre as a police service? And you kind of only have to go back to Helium principles, which still hold true today. So, you know, Sir Robert Peel talked about the role of the police in terms of prevention and detection of crime, keeping the king's peace, and protection of life and property. And attending the calls for service, for concern for welfare, for mental health, dealing with health and social care matters, actually had an unintended consequence, because it stopped us or prevented us from attending calls for service that did require a policing response, you know, where a crime had occurred or where there was a risk to life. And I can remember doing an audit. So we looked at 9 mental health incidents. And those 9 incidents took a total of 205 policing hours just to deal with those 9 logs. And that's the equivalent of dealing with 102 domestic abuse incidents. So no public sector organisation has unlimited resources. You know, we've got the resources that we've got. And, you know, the general demands on policing's increased. Policing's become more complex. So we needed to adapt our approach to, you know, non-crime demand. We needed to think as a system better how we dealt with health and social care issues. So we made a conscious decision that, you know, we needed to get back to doing what our core policing duties were, which is saving life, preventing, detecting crime, etc. Now, one of the key strengths around Right Care, Right Person, from my view, is that it's really grounded in our legal duties. And we spent a lot of time about this. You know, the Right Care, Right Person programme wasn't done overnight. We had 4 phases, which I'll come on to. And it took quite a lot of thinking, because we wanted to do this very carefully, very considered. And as part of that, we commissioned some advice from a KC, a barrister called Ian Skelt. And we got about 87 pages of legal advice. And we went back to him 11 times as our thinking matured, and we started to think through all of the what ifs. You know, when did we owe a legal duty? What did we need to do to discharge that duty? And it was really important as we developed policies, as we spoke to partners, as we asked our staff to make some what is difficult decisions, that we did so with a sound understanding around the legal basis behind it. So, as I say, we got that significant legal advice, and that forms a significant part of Right Care, Right Person. And our next principle is listening to feedback from our staff. So our then Chief Constable used to always go and he'd walk into parade rooms, speak to patrol officers. And it was, if I'm honest, their number one gripe, their number one frustration, that they were dealing with health and social care issues. And that was for a number of reasons. So first of all, you know, they could hear on the radio when they were sat, which could be up to 36 hours with somebody in a crisis suite. They could hear on the radio colleagues that were maybe putting out an assistance call, which is our emergency response, and they weren't able to go and help them. They could hear dispatchers in the force control room trying to deploy to a burglary in progress, and there was nobody available for it. So they were frustrated that they weren't able to do what their core duty was, what they joined the job for. And they were also frustrated because they didn't have the right skills and ability and training to be able to deal with mental health, because often it's really complex. So they didn't have the right skills and training to do that, and it impacted on their morale at the time. And one of the things now is Humberside has got one of the highest levels of morale from Police Federation surveys. So actually it was having an impact on morale, and I genuinely think that this has made a difference to our police officers. Our next principle was around partnership working. So one of the things that we set out right from the beginning was we were going to do this with and not to partners. So we could have pulled up the drawbridge, said we weren't going. We made a very conscious decision that to do this, we needed to do this as a system, and we needed to do this as a partnership. And it was a rocky road throughout. It wasn't an easy journey. We had to have some difficult conversations with partners, but we did it together, and we were really, really fortunate that we had really good working relationships with our partners locally. And I think that made a real difference. And a lot of the questions when other forces have come to speak with us, those partnership relations are absolutely key to making this work. And we set up task and finish groups. Partners looked at their policies and changed operating practice, etc. And we never got any kickback from partners in relation to this is the wrong thing to do. Unanimously, they all agreed that right care, right person, right care, right agency was absolutely the right thing to do. I think the concerns then moved to what does it mean to us? And some of their concerns I'll come on to later around the impact on their particular agency, but I'll cover that off shortly. But the principle of partnership working, doing this together, really key to right care. And then making sure that staff were properly trained and supported to be able to make decisions. So we put significant effort into making sure our staff were ready for this. So we trained all of our control room staff, we trained our patrol officers, our neighbourhood policing, our PVP. So it really was a full force endeavour. But we also, and probably more key than the training, is we offered floor walking when we went live. So we did 8 weeks of floor walking before going live with the first phase, which was concern for welfare. And we just needed to make sure that we had that support there to them, that we were able to give that lifetime feedback, whether somebody's made a good decision or if somebody had missed something out. But we really invested in upskilling our staff and supported them, and we put together a decision-making toolkit to help them to make those difficult decisions. And I'll again come on to later some of the cultural challenges we had to come, because this was one of the hurdles that we probably didn't recognise as much as we should have done. What a huge cultural challenge we had to overcome, because it is countercultural for staff who join the police because they want to help people. So it's kind of countercultural for them to say no or to signpost to another agency. So what is right care, right person? We split it up into 4 phases. So the first phase was concern for welfare. We went live in May 2020 with that. Phase 2 was AWOL, from mental health establishments and walk out of healthcare facilities. And I'll come on to each of these and what it means. Phase 3 was transportation, and phase 4 was section 136 of the Mental Health Act and voluntary mental health patients. So there was about 6 months between each of the phases. Bearing in mind we were starting this from scratch, so there was a lot of thinking to be done. There was a lot of conversations with partners, developing policies, training packages, etc. And we were not pressured. There was only me who had another day job, a couple of colleagues. So it was a really small team. Our now Chief Constable, Paul Anderson, was ACC at the time, and he wasn't putting us under pressure to particularly move quickly with this. So we did it in round about 2.5 years from start to finish. So phase 1, concern for welfare. I know we've got probably a mixed audience here today, so apologies for those that are already aware of what concern for welfare is, but our objective here was that partners in health and social care should conduct their own welfare checks. So I'll just start and say what a welfare check is. It's basically turning up at somebody's home address, kind of knocking on the door and asking if they're okay. And the types of calls we would get is a call from either mental health services or social services, typically at 4 o'clock on a Friday afternoon when maybe they were going off for the weekend, and they'd say, I'm really worried about Jimmy Bloggs. You know, they had an appointment on Tuesday and they never turned up for it. Would you be able to go and see if they were okay? And we would do that. So we would go and we'd knock on the door, see if they were okay, and often they would not be in. So we'd end up, because we'd taken that legal duty, that legal responsibility, we'd end up going back and back and back again. And we never really asked the relevant questions around, how worried are you? Why are you worried? What have you done so far? Why haven't you kind of been yourselves? And our view was that welfare checks should be conducted by the agency who's already involved with the individual or the family, the agency who owes a duty of care to them. And our partners were really nervous about this when we started to have the conversation, because they thought they were going to have to employ loads more staff. The reality was they just altered their operating practices. So rather than it being a Friday 4 o'clock worry, they risk assess better, and they would go, early in the week if they had that much of a concern for somebody. And that makes sure that the public are seen by the service they're engaged with, that continuity is maintained, and the person who goes to conduct the check is able to meet the care needs. So a much better, in my opinion, service to the public. So the next phase was phase 2, and this encompassed AWOL and walk out of health care facilities. So I'll just explain, again, I'm not sure what the audience is, I'll just explain what these are. So AWOL, absence without leave, this is where there's a section patient, so section in terms of mental health, who is absent without leave. So either they've absconded or they might have been allowed out on section 17 leave. So that can be either escorted with a member of staff from mental health services or unescorted. And again, I'll just give you a taste of the types of calls we were getting. So we were getting calls from mental health services saying they'd, lost a patient who was on escorted leave with a member of staff. One in particular, they'd last been seen in a pub, and could we go and locate them? So we'd send a patrol officer around to the home address, obvious place where to look, and we would then return them to the mental health facility. And for me, it just didn't feel like a good use of police time, or importantly, the right thing for the patient. So we worked with partners in mental health, and they changed their policies so that AWOL patients were no longer reported to the police as a matter of routine. So they accepted it was their legal duty to locate and return patients that were AWOL. We still support, so if there's a significant risk to the patient or others, then obviously we would support in those circumstances, but it's now an exception rather than the norm. And again, we always go back to the member of the public, and the benefit, I guess, is that relationship between the patient and the providers maintained, and that ongoing care and support isn't compromised by what is an unnecessary intervention by police officers. So phase 2 also included walkout of healthcare facilities, and we would get loads of calls around this. So busy ED departments, we've all probably been there. We know how busy they get, and on many occasions, people would decide to leave because they didn't want to wait to be seen. And you know, if they've got capacity, then you know they're allowed to do that. So one that springs to mind is, you know, we got a call from our emergency department locally saying a male had walked out with a cannula in his hand and could we go and locate him. So we deployed officers, and the obvious place where you would first go if you're wanting to locate somebody's home address. But when you think about it, when you go to the home address, what powers have we got? So this is why the legal advice is really important. What powers have we got to get the individual to go back to hospital? We haven't got any. So I guess we would use our powers of persuasion, and we'd either spend ages waiting for an ambulance or we'd bundle somebody in the back of a police car, which absolutely is not the right thing to do. So again, we worked with our acute hospitals, who I think it was just part of their policy. So, you know, no disrespect for the staff, but they'd go down the policy. Somebody leaves, right, what do we need to do? Bring police. Without actually thinking about what is the risk in that particular circumstances. And the example I gave you, it was somebody who had gone to hospital for irritable bowel syndrome. So we weren't talking Article 2 immediate risk to life. So they weren't risk assessing. And they once we got right care, right person in, just changed their policies to if they were concerned about somebody, they'd do a capacity test early on to see whether somebody had capacity to make a decision to leave. They would think about if somebody was a flight risk, where they placed them, you know, in the room or in the building. They would have their security staff and do some training for them. So all that happened in that instance is the acute hospitals changed their policies. And if I'm honest, when we went and spoke with the hospitals, they didn't realise they had a legal duty of care to their patients. I think the thought was, you know, as soon as somebody had crossed that hospital line, that was it. Their responsibility and their legal duty ended with that. But as we know, that's not necessarily the case. And going back to the member of the public, you know, we shouldn't have police officers knocking on somebody's door to ask them to go back to hospital to have a cannula taken out of the home. The third phase was transportation. So here, when we detain somebody under Section 136 of the Mental Health Act, I'll be honest, put my hands up, we would just put people in the back of a police car and transport them to crisis suites. So our officers here were not even bothering trying to ring ambulance. I think maybe because they'd had to wait previously, maybe because they thought ambulance colleagues would be busy and it's quicker for them to do it. But again, the principle of right care, right person, what is the right thing to do in those circumstances? And it's not putting somebody in the back of a police car who is mentally unwell. So again, we put in things in place so that, you know, we do call an ambulance on every occasion, and we have an escalation process, you know, after 30 minutes if the ambulance hasn't attended. But this is about not necessarily saving time for the police, because it's actually added to our time by making the officers wait, but it's the right thing to do for the member of the public. And then the final one was Section 136 of the Mental Health Act and voluntary mental health patients. So we were struggling locally to hand over to our mental health crisis staff in a timely manner, and you know, we had examples of patients being stuck outside for 5 hours in the freezing cold in the back of a police car, which, you know, isn't ideal. And some of our crisis suites didn't have necessarily 24/7 dedicated staff, so they had to pull staff off the ward if they got a Section 136 detention. So again, working with partners in mental health, this area did get an injection of money, so commissioners were involved. They managed to find money from elsewhere, and we've now got a much improved situation where we do hand over in a timely manner. Clearly, if somebody's violent, we'll still stay, but generally we do the risk assessment, which is a joint risk assessment with the staff, and then if we're able to leave, we leave as soon as we can do. And again, that gets our officers back dealing with, you know, crimes and other Article 2 issues that we need to deal with. I was just asked to cover off what the challenges were and the success factors. So in terms of the challenges, I mentioned already, but one of the key challenges was the cultural change that was required, particularly within our force control room. So first of all, it's countercultural for staff to say no. They join the police because they want to help people. So that was one of the hurdles. The second hurdle was, I think the staff were concerned because mental health's really complex. We were asking them to make what is, you know, sometimes difficult decisions. So they were concerned they didn't have the skills and the confidence to be able to do that. And then the final thing was, what happens if there's an adverse outcome? So again, how we overcame those was, first of all, by talking through the why. You know, this is about doing the best thing for the public and making sure that they get the service they deserve from the agency that's got the right skills and abilities. It was about making sure that we did the training, we did the floor walking, we put policies in place to safeguard them, and as long as they followed the policies, you know, and did that, they were absolutely fine. So we spent a lot of time with staff, and we have got our mental health lead actually based in our force control room. So we've also got Mind, which is obviously a national charity, within our force control room. So we have a lot of expertise around kind of mental health in the force control room for advice and support. The next bit was just some of our internal stakeholders' concerns, particularly in relation to our PVP, so protecting vulnerable people, colleagues. So they had some concerns, and then partnership concerns. So what does it mean for us? What are we going to have to do? I guess the key success factors, having mental health expertise in the force control room was really important. The training and the support for staff, which is still ongoing now, so some 4 years later. Doing it with and not two partners, so those partnership relations, and keeping those lines of communication open, and just debriefing things. You know, there were occasions, and we have an escalation process where there's a difference of opinion, but talking through those and making sure, and we've put a lot of effort into making sure that staff within the force control room make good decisions. So we never talk about the numbers to staff around how many we've deployed to or anything else like that. I always say to staff, you know, if you've done 100 logs and you've said yes 100 times, that's absolutely fine. It's about making good decisions. So yeah, the partnership relationship's key. Baseline and evaluation. So when we started this out, before we'd even gone live, I've done a document along with our performance and demand team around how we were going to evaluate this. So how we were going to measure, how we were going to evaluate it. So we did that, and we've done annual evaluations since going live. An engaged SRO, so senior responsible officer. For us, that was our now Chief Constable, Paul Anderson. So having somebody who is going to have those senior stakeholder conversations with chief execs from other agencies, that is going to, you know, help drive this was really key to us. And then the final two, grounded in legal advice and, as always, communications, because things fail or succeed on the, I guess, the success of the communications, really. So I'm just going to talk through the results for Right Care, Right Person. I won't spend too much time on this graph here. I guess the biggest savings, if you want to call it, in terms of the number of deployments was in phase 1. So that was concern for welfare. But a really nice kind of trajectory there in terms of reductions in deployments. So headline figures, 540 less deployments per month, a saving of 1,441 officer hours per month. That figure's a little bit outdated now, that goes up to December 22, but you can see there the stats in terms of overall officer hours saved. And at the peak, we were deploying to 78% of Right Care, Right Person incidents, so concern for welfare, mental health. At its lowest point, it was 25%. We're kind of hovering around 30, you know, early 30s now. So we've kind of found our norm now. But when you think, because they're big incident categories, it took 8% of deployment demand out of the system, which is significant for policing. And we were really keen to be able to show what did we do with that release capacity. So I mentioned the evaluations. So no surprise, we're dealing with more crime. So burglary, robbery, which are obviously neighbourhood crimes, high on the Home Office agenda. We were spending more time around that, deploying to more violent crime. And we were being more proactive, so calls in relation to suspicious incidents, our deployments went up around that, and our stop and searches, we saw an 86% increase in stop and searches because our officers were out and about and being able to be proactive instead of reactive. Our workbooks went down, our number of arrests went up, and we also used some of the release capacity to be able to reinvest in other areas of vulnerability. So we took officers from our patrol functions and we established a specialist locate team, which is a dedicated team looking at the management of missing persons. And again, this was a completely separate piece of work, but we saw some really impressive results around that. So bucking the national trend in terms of the reduction of missing persons. We were finding missing persons quicker. We had some really good success in terms of partnership work for repeat, frequent young missing persons. So again, some being able to use that capacity for other areas of vulnerability. And importantly, and the most important result in my book, is that members of the public have now receiving the right care from the right agency. I'm just going to finish off by just giving a slight overview around what happened after Humberside. So we had our HMIC inspection, and Right Care, Right Person was identified as innovative practice as part of that. And then there was a piece of work nationally around national productivity review. And again, Right Care, Right Person was identified as part of that. So as a result of that, the National Police Chiefs Council agreed to put some resource into this nationally to roll out Right Care, Right Person nationally. So that's in train. ACC Gilmer is the lead for that, and that's been in place since January. So it's a full year funded programme. So other forces are now starting to come on board. And one thing I should say is, although kind of the Right Care, Right Person package is kind of notoriously known for Humberside, there were a lot of forces out there that were already doing some of this, if not most of this, or things in a different guise that was equally as good. So we can't take the credit of that because we'd done benchmarking in the first place and we'd taken some ideas from other forces. But yeah, it's rolling out nationally. I have colleagues from New Zealand Police coming to Humberside next week. I have colleagues from Australia coming next month. So there's a lot of interest in Right Care, Right Person, and we're really proud locally around how we've delivered this, because we've really done it as a partnership endeavour, and you know, some of our partners have been put forward for health awards. So although I would have loved to have had a health colleague sat next to me, but it really is kind of standing shoulder to shoulder and working our way through this. I'm going to pause there. I've probably been speaking for much longer than I should have done. I'm more than happy to take any questions that anyone's got.
Thank you so much, Tracy. That was brilliant. And it was a fantastic introduction to the Right Care, Right Person. And thank you so much for sharing all your insights. Yeah, so there's a number of questions in the chat. So if anyone wants to ask a question, like I said, if you could pop it in the chat and put your name's already there, but also where you're from, that'd be really great. And Bami's going to sort of pick some out and share them in a second. So just to give her a minute, I've got one question that that seems to have come up a few times. So a few times, Tracy, you spoke about the partners that you work with when coming up with. So there's sort of two parts to that question. So who are those partners? And then how were those partners then resourced, I guess, to take on the work that the police were no longer doing?
So I guess local authorities, acute hospital, ambulance services, commissioners, mental health services. We did the rounds of CSPs, place boards, safeguarding adults, children's boards, etc. So a real wide range of partners. In the main, although partners were concerned, as I said earlier, about, you know, we're going to have to invest loads more resource into this, we're going to have to change contracts, we're going to have to work out of hours, all of that. A lot of it was just changing operating practices. So it didn't necessarily require an injection of money into it. The only place where that happened was for mental health crisis suites.
Yes.
So there was some investment in that to be able to have 24/7 dedicated reserves.
Yeah. And do you know where that investment came from for that?
I never quite know. I think it was a mixture of commissioning and, I want to say, finding some money out down the back of a sofa, but internally purposing some money.
Yeah, great. And I guess it will also be sort of different in every area. Like, you obviously speak for Humberside and how it works there, but every area will be responsible. Okay, Great. All right. Bammy, I'm going to hand over to you now to shout out some questions from the chat.
Thank you so much, Tracy. There's a couple of comments in the chat that's talking about experiences and a couple of thoughts around your presentation. There's a question that asks if all police officers were given mental health first aid training in your force.
Yes, we have had some of that, yeah.
That's great. And someone actually asked if you could give a definition of legal duty of care, just because they're not sure if it's clear for social or mental health services.
Okay, so I can give you a bit of an overview, but it probably takes 87 pages worth of legal advice trying to condense it.
Yeah.
But in essence, you've got Article 2, Article 3. So Article 2 is an immediate life. Article 3 is, in essence, serious harm. It talks about inhumane and degrading treatment. So they are commonly held, so for all public bodies. So you've got your Article 2, Article 3. You've then got your statutory powers. But outside of that, you are working at common law. And when you're working at common law, you have a choice. So for us, it was working through around when do we owe a legal duty of care? How do we, I guess, get that duty of care? How do we obtain it? And then how do we discharge it? So we kind of worked through different scenarios around, which is why our contact officers make the decisions, because at the point where you're saying whether it's to a partner or to a member of the public, yes, we will do this, then you're held to account and you've got to, I guess you've got to do what you said you've got to do. So our contact officers make those decisions, and some forces that have maybe been to see us previously, that decision, we say yes at the first point of call, and then somewhere down the line it gets to a patrol sergeant who says, why are we going to this? We're not going. You've already assumed the duty of care in those circumstances. And there was quite a few cases that Ian Scout, the barrister, sent through to us to kind of give an example of how you discharge a duty of care.
Great, thank you, Tracy. And there's a lot around kind of the gap and I guess the underfunding of mental health services, and how it's difficult to refer people to something that doesn't exist. So how are you able to fill this gap, or how are you able to work with partners to ensure that they were consulted and aware of what was going on?
As I say, we had a task and finish group that we set up. So we'd have monthly meetings with partners. I must say, one of the things that we always say to other forces that come to visit is, do you actually know your demand? Because we talk around mental health, but actually crisis is that bit of what we deal with. So a lot of the calls that were coming into us wasn't clinically recognised mental health. It was actually, as I say, concern for welfare. I'm concerned around either an elderly neighbour. I haven't seen them for a couple of days. I think they might have tripped up, or actually I'm concerned about my neighbour. He's had some mental health issues. I haven't seen them for a couple of days, and that's where our questioning comes in to try and ascertain, is this a health concern or not, and who is the right agency? You've then got self-harm. You've got suicidal ideation. So what if somebody's talking about suicide? So it's not an Article 2 immediate risk to life. Somebody's talking about potentially committing suicide in the future, or a lot of it was emotional dysregulation. So actually, I'm just really struggling with the day-to-day challenges that life throws at you. Now we've got mind within our force control room, which is for me, it's a really good asset, because we considered, do we have clinicians in there? But actually, as I say, the majority of things that were coming through to us wasn't at that acute stage. And people just wanted somebody to talk to. So that was really good asset for us. That was funded jointly between us and mental health providers. But in short, it's about, we never ever said to partners, this is how you should fill your gap.
Yeah.
For us, if it's a health issue, then it's down to health or social care, whichever it is, to determine how they're going to fill their own gaps in there. And if I'm honest, this shined a light on it. We never had a whole system conversation before here, and this started the conversation around what are we going to do differently as a system.
We've got a question about whether you've seen any changes in arrest numbers since introducing Right Care, Right Person, and also following from that, were there any reductions in assaults on police?
Don't know whether I'll be able to answer both of those. So are we talking general arrests or detention under section 136 or anything in particular?
I'm assuming general arrests. So maybe when you've come across someone and it's clear that they're suffering from a mental health crisis at the point of arrest, and now that there's a different strategy.
So just general arrest, our arrest rates are quite high because we're able to be out there and be more proactive. If you're talking about section 136, then we always ring our crisis suites for advice before we detain somebody. So it's not necessarily saying a joint decision, but we seek advice from them around the background and around somebody, whether we should detain or not. So recently, in the last month, there's been an increase, but generally, we look at those figures collectively on a monthly basis with our partners to kind of understand. I don't know if that answers the question or not.
No, thank you. And we've got another question. Have you engaged with lived experience groups to get the views of people who use mental health and social care services? It would be good to have their perspective.
Do you know, it would be really good to have perspective. At the first meeting that we called, so we brought all the partners in, and I really wanted to do a whole system evaluation, which would have included lived experience, see the journey through. There wasn't necessarily appetite for that at the time. So although we've done quite a thorough, I think, evaluation from a policing perspective, I guess we're relying on our partners because ultimately it's their patients to be able to do their own evaluations on that. So that's not as, I guess, as tight as I would have liked it. So when we talk about lessons learned, what would we do differently? I'd have loved to do that. Fortunately, with the national work, we've got the Department for Health and Social Care, and we've got the Policing Policy Unit who are working up kind of baselining and evaluation. And I've had discussions with them. You know, I'm hopeful that something will be kind of included around lived experience around that. But anecdotal feedback from partners has been positive.
Thank you. I'm just conscious of time, but there's quite a few questions that that are quite specific. So I think it would be great if we could send them to you, and maybe you can have a look at them another time, and we can send a response to those people. But we've got some great questions from people from Police Scotland and also from the National Youth Agency. So really great representation. But yeah, I'm sure we'll be able to answer any questions that weren't answered in a follow-up email.
Fabulous.
Thank you, Bami.
Thank you for inviting me.
Yeah, so like Bami said, we're sort of drawing to an end, so sorry we couldn't get to all your questions, but like Bami said, hopefully we can we will share them with Tracy, and hopefully we can get some answers to all your questions. So just want to say another big thank you for Tracy for also for doing this all on her own. It was supposed to be 2 people, and she's very kindly took on the whole event on her shoulders, so thank you. That was really interesting and really useful, and hopefully it will spark much more conversation and interest in this subject. And a big thank you to Miranda, who works at the Centre for Justice Innovation, for organising this and set it up. It's been brilliant. Thank you, Miranda. So like we said, the recording will be available very shortly. And if you have any other questions, pop them in the chat, or you can contact Miranda and she'll put her email address in there as well if you've got any other questions you want to ask about our work or this this presentation as well. So thank you all very much. It's been lovely, and yeah, we hope to see you at another one of our Expert Voices events soon. So thank you, everybody, and thank you again to Tracy.
Thank you. Cheers, everyone. Have a good weekend.
Bye. Bye, everyone.